All right. Well, good afternoon to everyone on the East Coast and morning to everybody else in the U.S. Glad to have you with us today. Today's, today's school HBCU shout outs to Gremlin, my dad's school, GSU. But I'm glad to have you all here today for a little bit of dose of some real Black girl magic. These three women I've gotten the opportunity to work with over the last several years. We have, obviously, we have Mia, who I always work with, who was at one point ran the Health Braintrust up to about a year and some change ago. Then we have Dr. LaTasha H, who works with us at the National Minority Quality Forum. She is our newest employee that's doing clinical research and development. And then finally, we have Nicole Varner, who is our new executive director of the CBC. They're just going to give you an update on all the work the organizations are up to and some things that you should be focusing on in the fall. So without further ado, Mia, I'll let you, as usual, take over.
Brandon, I appreciate you and NMQF for always convening us and bringing just really very synergistic and just overall fantastic panelists. I am probably really biased toward this panel, as you've alluded, for several reasons. One, I'm definitely joined by friends. And then two, just the brilliance that the two of these women and this gentleman just exude and lead with, and also just overall passion for people and for the work that they do. I'm really very grateful to be here today. So as Brandon mentioned, we're going to have a really very riveting conversation today, just getting into some critical updates with respect to the state of health here in the nation from a congressional standpoint. Nicole's going to bring us some good word from the House of Representatives, and then Dr. LaTasha H is going to talk to us about making some research connections. And so we expect that you all will be interacting as you usually do, audience members. So just make sure that for whatever questions you have, please place them in the question and answer box, which is just below. And then if you have things that you want to just brainstorm or bring to your fellow audience members' attention, put it in the chat box that's next. I think that's this way on your screen. It's actually this way on my screen. But chat box, conversations here, discussions, questions down below. All right. Without further ado, I'm opening up to LaTasha H to lead us through some a critical discussion, and then we're going to go ahead and get into it. Tash.
Thanks, everyone. Mia, can you confirm that you can see my slides? Perfect. So thank you so much, Mia, for the opportunity to join you today. I have been tuning into these webinars for the last several months and find them extremely informative. By way of introduction, I'm LaTasha H. I am the newest member of the National Minority Quality Forum, where I serve as Vice President of Social and Clinical Research and Development. I am really excited to be in this role because I've really focused a lot of my attention since finishing my doctorate on health disparities and, in that regard, health inequities. And so I'm really wanting to chat with you today about some of the health disparities that we are witnessing as a result of COVID-19. So many of us in this healthcare space are very familiar with these words. They're often, invoked words that were attributed to the Reverend Dr. Martin Luther King Jr., and they really offer a moral sustenance to us who are working in this field, because this powerful quote and claim really helps us to all align. And over the next several minutes, I'm really going to set up the case for why some of these health disparities really are a social justice issue and what we are really needing to do as a broader community, and also specifically what the NMQF is going to be doing in regards to these disparities. While the quote you see on the screen is what's often remembered, what he actually said is, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane because it results in physical death. And the physical death piece is the piece that I want to focus on, because I'm going to cover over the next couple of slides COVID-19 as well as two other diseases that result in death and morbidity in our communities of color. So next slide. So we are in the midst of this COVID-19 pandemic. And with that, I really wanted to share this recent finding by the Kaiser Family Foundation. You know, COVID-19 has really shone a light on the disproportionate impacts that this disease has had on communities of color, particularly the availability of data, or lack of availability of data, has really kind of crippled us in really understanding what these disparities are and how they can be addressed. So NMQF is launching a COVID-19 study, which I hope to provide you an update on later this year. But what this brief found is that in communities of color, there's a disproportionate burden that results in death, but also cases and hospitalizations. What they found in particular is in these states highlighted in orange, these are areas where African American deaths are higher than their share of the total population in those particular geographies. So this brings about, why are we seeing these differences? You know, these are inequities. You know, equities bring up the conversation of the social determinants of health. You know, you think of our communities, sometimes we think of crowded situations. We talk about close contact with, you know, we have large families, or we're living in urban environments, in closed spaces, such as sharing apartment buildings and having to go in elevators or crowded staircases. And also because, you know, a number of individuals in our community are essential workers or have gone back to work. And so they have a longer exposure. And so on the slide, you actually see the percentage differences that the CDC found related to Native Americans and Asians, it's Black, as well as Hispanic or Latinx members of the community, where all of these groups experience high or elevated number of cases, elevated hospitalizations, but also elevated deaths. So we really need to understand this data better to really bring about change. So when you think about this, there's also the underlying health issues that individuals and communities of color are facing. So there is increased asthma in our communities, there's increased hypertension, which is a 3 times increase in terms of the hospitalization associated with COVID-19 and that underlying health condition. Obesity is 3 times higher, and I know we covered obesity in a recent talk. Diabetes, which I'll talk on a little later. Chronic kidney disease, severe obesity, and other conditions. And so the 2 other conditions is really interesting, because today I really want to talk to you about one disease, and that's why I'm wearing red today. Sickle cell disease, which is near and dear to my heart because I have family members who both have disease and trait, and that's the area of research that I was working in prior to joining NMQF. So I'm really taking this article, I'm sorry I didn't put the citation, that Dr. Fauci mentioned in I think it was April. This quote really resonated, where Dr. Fauci said, "Coronavirus is shining a bright light on the unacceptable health disparities, especially in African Americans." He equated this to what was seen during the HIV crisis. And we know from the data I just showed you that there are health disparities across the board in our communities of color. We know that Latinx individuals are more likely to be diabetic compared to their white counterparts, that African Americans are more likely to have stroke, that, you know, our Native American community are more likely to have heart disease, and that Asian and Pacific Islanders are about 80% more likely to have liver cancer and other cirrhosis. So I really want to take a look at some of the health disparities that, you know, Congresswoman Kelly and members of the Congressional Black Caucus and the Health Braintrust have really focused on over the past several years. And so the first disease I want to focus on is sickle cell disease. So many of you may not be familiar with sickle cell disease, but it is an inherited blood disorder that typically in your body, your blood is kind of like a flexible donut or a disc, and it's able to go through the small blood vessels in your body. However, with sickle cell disease, there's one genetic mutation that results in a whole host of complications. These normal red blood cells that used to be round and flexible are now stiff and rigid, and they're unable to move through the body. And that presents a lot of challenges. Some people know it as sickle cell anemia, and the anemia is related to the fact that blood, typically, the heme portion of it is the portion that carries the oxygen. And in these individuals, there is a decreased oxygen carrying capacity. So these misshapen blood cells are crescents because they look like a sickle, which is a garden tool that was utilized a lot in sub-Saharan Africa where this disease was, causes a number of painful complications. It can result in stroke, it can result in kidney failure, it can result in a whole host of issues in individuals, and it's really the hallmark is pain. But we know that there are a number of disparities associated with this disease, which are being exacerbated during this COVID-19 pandemic. Those include life expectancy, which we see there's a 30 years shorter than the average African-American of the same age, of the same gender. We see increased hospitalization rates, the increased rate of stroke. My little cousin, Christina, who has the disease, has suffered both a stroke and an aneurysm as a result of sickle cell disease. There's also resource disparities. We know from the data, both that the CDC has done, as well as NMQF's own sickle cell disease index, that the majority of sickle cell patients are Medicaid insured, with another 20-some-odd% being Medicare insured. So that presents a challenge for our federal partners to consider how to reduce some of these inequities and disparities. And we also have to think about this in the context of social justice and implicit bias. We see that individuals have barriers to obtaining adequate care, appropriate care, and just standard of care. They experience longer wait times. They don't get pain medication when it's deemed necessary. This is a painful disease. We're dealing with the COVID-19 issue. We're dealing with the opioid crisis, but yet they're considered drug seeking. But this is the nature of their disease. And lastly, there is a disparity in the number of trained physicians who know how to care for sickle cell disease. So I put this slide in here because Brandon and I were talking. When you do a tale of two diseases and you look at sickle cell disease, a rare condition, and cystic fibrosis, another rare condition, this 2020 paper by Farouk and also J.J. Strauss highlighted, in a health policy perspective, disparities in funding, both for the research as well as at the federal, state, and foundation level, that there are really challenging issues in terms of the number of therapeutics, the amount of research, and everything taking place between these two very similar diseases with different populations, where sickle cell disease is primarily minority communities, African American, Latinx, and Indian, East Indian, and cystic fibrosis, which is primarily a Caucasian disease. The next disease I want to just briefly chat on before we kind of send it back to our illustrious moderator is diabetes. We know diabetes affects over 30 million people. We know that there's two types, but when we start talking about African American community, we really are looking at type 2 diabetes, and there's disparities in care there. I apologize, there's a lot on this slide, but in the interest of time, maybe we can talk about some of these during some of the discussion. But there are disparities, particularly in our Latinx community, as well as the Asian community, where collectively they account for about 23% of the population, but are at higher risk of prediabetes and type 2 diabetes. And it really is exacerbated when you look at BMI and other conditions. And so how is this being impacted by COVID-19? I really want to kind of get into that discussion later and talk about what are some strategies that we as a community should do. And lastly, I must always highlight what the NMQF is doing. So NMQF has a number of indices, and they're highlighted here, especially in sickle cell and diabetes, but we also have cardiovascular disease and others. So that is all I have. I want to turn things back over to Mia to introduce Nicole.
I think now you can hear me. Yeah, as usual, Tasha, that was just a really very vivid overview of what we're dealing with as a nation with respect to the overall equity conversation. And then we really appreciate you highlighting sickle cell disease and cystic fibrosis and just overall how we need to be thinking about these issues, both from a moral or really completely from a moral perspective, from clinical perspectives, from research perspective, economics and business. And now I'm really excited for Nicole to help us think through how we need to be thinking about this from a policy perspective and what this looks like in a highly politicized climate. So I want to turn it over to Nicole for some opening comments and then any reactions also to LaTasha's slides.
Thank you, Mia. I really appreciate that. It's such a pleasure to be with you all here today. Thank you so much for having me. As Mia said, my name is Nicole Varner. I'm the Executive Director of the Congressional Black Caucus Health Braintrust under the phenomenal chairwomanship of Representative Robin Kelly. I could not be here today without the path that Mia blazed. But today I want to cover a few things that we're working on during the pandemic to try to tackle the health disparities that we see every day, not just during COVID-19, but as Tasha mentioned, COVID-19 has definitely shone a light on these disparities in a way that I think was not expected and made the broader population aware of the things that are really going on in our healthcare system. So I'm going to cover a disparities mega bill that we have been working on for the past couple weeks, months, potential clinical trials legislation that we are contemplating. As you know, we are working not we, but the pharma companies and CDC, NIH are working very diligently to find a vaccine. And we want to ensure that there's representation of minorities in these vaccine trial populations. And finally, I'm going to touch on maternal mortality during COVID, because that is an issue that's near and dear to my chairwoman's heart. So I'll start with the disparities mega bill. And I apologize that I am not as prepared as Tasha, so I don't have slides, but I will just kind of go through the titles a little bit to give you an idea. This legislation has not yet been introduced. It should be introduced in the next week or so, but we have gotten Caucus sign on, and we are working to get sign on from the entire Democratic caucus, and hopefully some of the Republican members as well. So the first title basically covers racial and ethnicity data collection. We find that the collection of data is lacking for African Americans, Latinos, the Asian population, and without those numbers, we're not getting a clear picture of the disparities and the effects of health issues, especially COVID right now, in those communities. Second, we're gonna cover equitable testing and tracing. The third title, free treatment for all Americans. This is a disease that COVID is a disease that we don't have any control over. You walk by someone and you contract it. And with so many Americans being uninsured or underinsured, we need to ensure that all people are able to get a vaccine and not be bankrupt or have to pay exorbitant amounts for these treatments. We are covering expanded insurance access, ensuring that there's a Medicaid special enrollment period for folks residing in COVID emergency areas, special enrollment period through the exchanges for the same period or for the same areas. We also have included the Mamas Act, which is Congresswoman Kelly's, maternal mortality mega bill. And we would allow for medical assistance under Medicaid for inmates for 30 days preceding their release. That way, once they come out of incarceration, they are already enrolled in the program and able to take advantage of those healthcare services, which in turn will save money. We, excuse me, we have covered community-based grants, grants for racial and ethnic approaches to community health, including culturally and linguistically competent care, aid to providers serving minority communities. It's very important that we have this linguistically and culturally appropriate care for folks who are not only suffering from COVID, but are suffering from other health issues, because we have to be sure that we're meeting people where they are, not where we want them to be. We are including temporary increase in Medicaid dish allotments, COVID-19 related temporary increase of the FMAP for Medicaid, which is just the federal matching for states in the Medicaid program. Health IT and the digital and bridging the digital divide in healthcare. We are huge proponents of telehealth. It's anecdotally stated that folks who are using telehealth now are keeping their appointments more regularly. They're not seeking to find transportation, childcare. They are able to just sit down at their computers or use their cell phones and connect with a physician. While we realize telehealth is not ideal for every condition, it definitely is a starting point for a lot of people who live in areas that either don't have a provider or they live in rural areas. But in conjunction with those rural areas and underserved urban areas, we have to ensure that the infrastructure is there, which is why we are also bridging the digital divide. We also have included in this mega bill, and I apologize that I'm still on the mega bill, but it is a mega bill.
No apologies at all. Give it to us. We want a thorough summary. And so please keep going.
Thank you. We also have included funding for public awareness campaigns. But along with these public awareness campaigns, we want to increase the understanding of and improvement of health literacy. So many people in the United States do not have an understanding of basic health literacy, how to talk to a physician or a healthcare provider in such a way to get the type of care that you actually need, and to understand what it is that they are saying back to you. That's one of the most important tools to advocate for yourself. And so, you know, it's important to be included in the hopes that we can kind of bring the level up. We have included funding for research, CDC field studies pertaining to specific health inequities, data collection and analysis grants to minority serving institutions, safety and effectiveness of drugs with respect to racial and ethnic background, and tribal funding to research health inequities, including COVID-19. Finally, we have an education title, which would provide grants for schools of medicine in diverse and underserved areas, and public health assistance to tribes. And so that is basically a quick summary of the Disparities mega bill. We're hoping that some of the provisions included, which also encompasses HIA, if you all are familiar with that bill, and other bills that have been introduced by Congresswoman Kelly's colleagues in the House, have been folded into this one bill in the hopes that we can, you know, get it through in the next month or so, and really get some understanding of health inequities, get some good data, bridge the gap, and create ways to close the inequities and bridge the gap in healthcare treatment. Next, I'm going to move on to our clinical trials bill. This also is a bill that is pending introduction, so I'm going to go over it a little bit more quickly. But the most important part of this bill is designing inclusive clinical trials. Dr. Fauci said that the clinical trials will enroll 30,000 people, but there is no mandate on how many minorities have to be included in that number of 30,000, which is problematic. We historically have a underrepresentation of minorities, whether that be African Americans, Latinx individuals, Asian American individuals, and without having a good representation of the broad swath of Americans, we're really doing ourselves and others a disservice in creating vaccines. But we are asking for this bill to give in order to submit an application for a clinical trial to any federal agency, there must be language recognizing inequalities and clear and measurable goals for study participant diversity based on the health inequities and demographics listed in Part A, and provide a rationale for the goals. Next, we want to make sure that there is an equal opportunity to participate. That means, excuse me, eliminating cost barriers to participants. Quite often, there is a cost associated with getting to the area where the trials are being held. There are childcare costs associated with, those participants that have children. So we want to ensure that the clinical trials will cover participant expenses related to participation in the clinical trials, which includes missed or foregone salary, meals, childcare expenses, lodging or hotel expenses, transportation, and other expenses as identified by the participant. And we understand that these requirements may be required to be flexible, but we think it's a good starting point. We also want to include participation by Medicaid beneficiaries in approved clinical trials. Quite often, those folks who are enrolled in Medicaid are prohibited from enrolling in clinical trials due to the fact that they are covered by Medicaid. Title III would cover awareness and outreach to underrepresented groups, presenting awareness campaigns that would make folks aware of the fact that these clinical trials are taking place. Too often we find that people are unaware of clinical trials that are taking place, therefore they can't enroll, and this, they may be part of the populations that we actually need to enroll in the trials. And then there are grants for outreach. And that would just be grants, obviously, to conduct outreach for awareness for individuals. Lastly, I'm going to cover just briefly maternal mortality and COVID-19. According to a number of sources, maternal mortality, especially in the Black community, has increased to a degree due to COVID-19. There have been reports of mothers' birthing plans being changed at the last minute, and unfortunately, these individuals don't have their partner or doula or midwife or whomever they choose to be part of their birthing plan in the delivery room with them as was planned, which means they are not there with an advocate. Many people are frightened in the moment. I mean, you want to make sure you're doing the best thing for your baby. And when it's just you and the doctors and the nurses pressuring you to have a C-section, which we know leads to higher rates of maternal mortality, it's difficult to advocate for yourself. Secondarily, we're finding that mothers are not attending their prenatal appointments in the same way that they were previous to the pandemic. Whether that be because they're afraid of going into the hospital or birthing centers due to COVID-19, or because they don't have access. That is one of the issues, another of the issues that we are finding. And as we know, African American women are dying during and from childbirth at a much higher rate than our peers in any other demographic. And the Healthy Moms Act, my boss has introduced for the last 3 Congresses, Mia? 3 Congresses, would extend Medicaid coverage postpartum for a year instead of for 60 days, which is an important part of fighting maternal mortality. But also we need to find a way to incorporate more doulas and more midwives, support people, and culturally competent care into the maternal health space. So the Congresswoman has convened a number of panels. In fact, we will be doing one in a week, and we'll be discussing the importance of finding culturally and linguistically competent care, having a birth plan, having an advocate with you during your birthing and just overall the importance of not only having telehealth visits during this time for your prenatal visits, but actually going into an office, actually having a doctor to listen to fetal heartbeat, touching, feeling, really manipulating the mother to ensure that the baby and mom are healthy. And with that, I am going to pass it back to Mia, and we can take some questions.
Nicole, thank you. That was so thorough. And I will say never apologize for going in depth, because what we're talking about essentially is lives, right? We're talking about lives, we're talking about preserving lives. We're talking about really uplifting conversations that bring a level of consciousness to our health system in a way that might be new for other people, right? Which brings me to a question that I want to pose to the two of you. But before I do, someone asked whether or not the mega bill language is available. It's not yet been introduced, so the language itself is not available to the public. But what I will say to the audience, because Nicole mentioned a bill called HEA, and HEA stands for the Health Equity Accountability Act. It's been introduced in every Congress since 2010, initially under the leadership of the previous chairwoman of the Congressional Black Caucus Health Braintrust, delegate to the U.S. Virgin Islands, Dr. Donna Christensen, who is a good friend of the National Minority Equality Forum. So you can look up HEA, and I will tell you, it is hundreds of pages long. But many of the tenets that Nicole has mentioned today are prefaced in HEA. So if you study that document, you will very much walk away with a great sense of what you will see in the mega bill that Congresswoman Kelly is introducing, that Nicole so graciously laid out for us. So back to this question that I have for you two. You know, I think the nation in a lot of ways is thinking of COVID-19 as a moment, right? But that impacts the way that we live our lives, and we will eventually get back to, right? A lot of people might have that tenor, but we know better. It's not a moment. This is momentous, right? And this is something that's completely changed the trajectory of our world, as well as and certainly that us being in the U.S., our country. And so I'm wondering if you two can talk to us about really the staying power of the message of, you know, the need for equity to be infused into our policies, Nicole, and also into our research. And by research, I mean every facet of research, from clinical trials to bench science, to the ways in which we even translate the science into a lay fashion. So do you feel that the conversation of equity will stay with us such that it becomes a part of our institutional DNA? And by institutions here, I'm talking about the realms that you two represent.
I'll start off. You know, Mia, you really hit it on the head. I think this conversation is one that I really challenge the audience to take up. We're in this whole movement of Black Lives Matter, but Black health matters. There was a really great talk I saw recently about that. And we really must look at these as social justice issues. You know, we look back, 50 plus years ago during the civil rights era and what they were able to accomplish. And subsequently, since I touched on sickle cell disease in the 70s, where they were able to get the sickle cell legislation. We must not just protest, we must vote, we must act, and we must continue to bring awareness to the disparities that our communities are facing. And this is from the Hill all the way to the bench for this research side, all the way to the bedside. Because even if we have therapeutics, are they actually getting into the hands of the people that need them? And is there equitable care there? Because we know that there is institutional racism in the healthcare system. And what can we do to break down some of those walls? It's going to be important to have discussions and continue to have discussions. Just because we, pass one piece of legislation doesn't mean that it's fixed. It's the implementation that is needed next, and ensuring that the voices of those who are being disenfranchised and affected by all these disorders are having their voice heard, and that they're providing solutions that work in their local communities.
So to piggyback off of what Tasha said, I think that it's innumerably important to continue to have these conversations. We are in an era where COVID-19 is top of mind, and it has shined a light on these disparities. But these disparities have existed for centuries. I will say I am encouraged by, the number of minority individuals who are being elected to Congress every cycle. It seems to be increasing, and I hope we continue to trend in that direction, because those are the folks that we will be able to work with who can continue to beat the drum. A lot of our icons are not going to be able to do it forever. And so we, as the younger generation, we have to vote. We have to keep up the drumbeat. We have to run for Congress. We have to continue to push legislation like the Disparities Mega Bill. If we can only strip out, 2 or 3 provisions from that bill and they get passed, that's wonderful. But we have to continue to have these conversations, and we have to continue to press forward. We can't, after COVID is over and we've moved on to the next thing, we can't let it die. We have to continue to think about these things. And I've been so encouraged by the number of minorities at pharmaceutical companies who have reached out to us and said, hey, we're here, we understand, we're in these rooms, we're having these conversations, whereas even 10 years ago, that wasn't the case. But we still have more work to do. We still have to continue to hold pharmaceutical companies and the agencies accountable for how they conduct clinical trials and how they do research, how they do data collection. We have to ensure that we are going to be counted. But also we have to fill out the census. If they don't know that we're here, they don't know that these things are a priority for us. There are so many ways that we have to fight the racism that is just inherently in the system. But it's on us to do the work, because nobody else is going to do it for us.
And then also I will add to that allyship is important, right? And the work of equity cannot fall solely on the shoulders and really the weary soldiers of the soldiers, the shoulders of the soldiers. You all know what I'm saying.
Yes.
Right. Who have been beating that drum for so long, right? And so the conversation of equity is not one that only impacts and will frankly benefit those who are historically marginalized and minoritized. It benefits us all. And so for a consciousness to be raised also, to your point, Nicole, amongst those who are newer to the space, in terms of policy, in terms of academia, literally the more the merrier, because we're not going to be able to do this on our own. It is not just a Democratic thing. It is not just a people of color, Black and Indigenous thing, right? It's all of us. And I know that there's a question that was raised about, tackling inequities from an intersectional lens, right? If you read HIA is nothing but policy of intersectionality, right? And it's really the parent-child to what you're talking about is happening, that Congresswoman Kelly is leading in the House, and then also her colleagues, because the Congressional Hispanic Caucus has introduced HIA this year. And so really also being quite attuned to what's going on in Representative Chuy Garcia's camp, because he's leading that effort right now. And then also looking at what's going on across the chambers, right? Because the one fight is in the House, but we've got to get the bills passed in the Senate. And if the conversation about equity is not valued in the Senate, it's just going to sit pretty, right? And so that's one thing. I want to ask the audience a question, right? Because LaTasha laid out for us the significance of two rare conditions, painful conditions, costly conditions, right? And we're talking about moving the needle with respect to equity. It's not just the conversation, it's also the appropriations, the money, the funding to it, right? And so for the audience, I want to know from you, what do you think in terms of the health disparities and health inequities? What are the priorities for you in research and policies and programming? We'd like for you to select your top 3, and then we'll come back to that. And then also this will help us to consider how we will raise additional conversations moving forward. What we don't want to do is get into this whole thing of, struggle Olympics between conditions. That's not what this is about, but we really do want to know how you feel. And I'm going to go ahead and fill this out for myself too. All right, there we go. So I'm going to throw another question your way. Tell us about, because I'd be remiss if we didn't acknowledge that today is the 11th of September, right? And in 2001, our country, I know where I was sitting in I guess I was in 9th grade or 7th grade, one of those. I was little, but I knew what was happening, right? We may not have been able to understand the ramifications of it, but what is very clear to us is the resiliency of the human spirit and the capacity at which the nation is able to come together to really rally against anything that threatens not just our well-being, but threatens our ability to love each other, right? In the sense that we do have to rise to the occasion and have hard conversations. And a hard conversation to have has to do with health inequities as well, but more so about how we value human life. And so I'm wondering, in the spirit of human resiliency, how do we need to think about COVID-19 right now as a threat, not just to health, but to the health and security of the nation, and the way in which we view each other?
Such a wonderfully framed question, Mia. When you first said resiliency, I thought about 2 unique groups. I thought about our frontline workers who are battling this disease in a healthcare setting day in and day out, and the resiliency that they have to display. This has been a big topic. I know the AMA has touched upon it. My former employer at the American Society of Hematology has touched on it. In the healthcare system, there's a lot of burnout. And one thing I really would love for institutions and organizations and even the general public to do is to have a respect of what these people are going through day in and day out. You see people post on their social media. I follow a lot of doctors who, say that, for the sake of their household, they, created a camper out in their parking, area or on the street so that they're not exposing their family members to COVID-19. And we're now in September, and that's been since March or earlier, February and January, depending on where these people are. And they give their heart and soul to caring for individuals, and I really applaud them for their work. But I think also their particular systems must create programs to provide counseling, because they're internalizing a lot. They're seeing people very ill, they're seeing people intubated, they're seeing death, and it's very important to recognize that. But I also think of the resiliency of our communities. Our communities are facing this disease, and many people are isolated. You talk about some of those rare diseases, they can't even be around their families because their immune systems are weakened, and they've been in the home and not seen people or done things since March when we started quarantining, and the resiliency that they have to display. And then lastly, the resiliency of our nation. We are going to get out of this. I know, there's all these people who don't believe it's real, but we are going to get out of this. And the lessons learned from that is going to be important for us to take to addressing other diseases. And there's amazing strategies that have come out around COVID-19, and I know we'll talk about clinical trials later, but there's some amazing strategies in clinical trials that have resulted from COVID-19, and I think it's just part of our human being, like our actually being and living that we're experiencing, that is really gonna change things moving forward. We just can't give up.
I think I definitely agree with Tasha regarding, the need for mental health services to be accessible to first responders, whether that be EMTs, whether that be police officers, physicians, nurses, whomever, and we are working on legislation that would provide mental health services for these frontline folks. And it is difficult to see the light at the end of the tunnel right now, but we will get past this, and we will get past this and learn lessons that will apply to future issues. This will not be the last time something will hit our shores. I hate to be dark and dramatic, but it's true. But mask wearing if you're sick in public, I hope that becomes something that is common practice after this. It's done in a lot of other countries, and I think, despite the fact that there are folks who don't want to do it here, it's important that we take care of one another, because that's the only way we're going to be able to move past this and resume some sort of normalcy in our lives. But I think we can do it. I think we just have to be mindful. If you need a sparkly mask, get a sparkly mask. It's fine. But we all have to just take care of one another and band together like we did after 9/11 in 2001. I was in theology class because I'm a Catholic schoolgirl, and we started to pray. So, we just have to band together like we did then, and we'll get through this together.
I want a sparkly mask. So wherever I can get one, just slide that and shoot me a text message, Nicole. But no, I have to say, I'm so encouraged by the both of you displaying such leadership and also optimism, without this sense of being strategyless, right? Because it's quite clear that both optimism and strategy can live side by side with the work that you're doing. And you both mentioned in your answers, alluded to clinical trials. And I want to talk about clinical trials, and I don't think I ever thought about it in this way, but as you were talking, Nicole, I was thinking about how can we think of the ways in which clinical trials are a part of what you just brought up, which is taking care of one another, right? And so I'm wondering to what extent you think we will be able to really uplift that notion as we move forward in clinical trial efforts around COVID-19 vaccines, clinical trials in general with respect to greater representativeness as our nation changes demographically and rapidly so, right? So talk to us a bit about that.
We've discussed a lot around African American enrollment in clinical trials, but I haven't really talked a lot about Native American enrollment in clinical trials. And as we all know, historically, the healthcare industry has not created an environment where people feel that they can trust clinical trials. People were told they're getting one thing and another is happening. Babies are being, injected with experimental drugs at points in our history. So I think in order to really create a more diverse pool of candidates, we have to have the manufacturing companies to really get out in the communities and really talk about what it means to be enrolled in a clinical trial, what safeguards there are. Like, I was on Twitter or Facebook the other day and somebody was like, oh, don't get the vaccine, they're just going to give you COVID. Like, no, they're not. But we have to combat that thought process, because that's what people are thinking, because there have been so many dark and treacherous and leery things that have gone on in the past. We have to, make it clear that there are systems in place that, recently there was a trial who said, hey, listen, we've got a mysterious illness in this patient. We're stopping this whole trial until we get to the bottom of that. That's not just for their safety. It's for our safety, because if they continue, we don't know what is happening with that person. And there's also, a fund for folks who do suffer ill effects from vaccines. I don't want to paint it as though nobody will ever have a bad reaction to a vaccine trial. We have to be realistic about that, but we also have to be aware of what is out there to assist that person with any ongoing issues resulting from the vaccine trial that they participated in. And, a lot of the funding that we have for awareness campaigns and, in the bill, we really have to direct those funds to marginalized communities, the Native American community, African American, Latinx community. And we have to be, intentional and thoughtful about the messages that we are disseminating to people, and myth busting, if you will. But being realistic and telling people this isn't going to be a silver bullet. That's why it's a trial.
And I'll add to that list also LGBTQIA members, right? For sure. Because the stigma is so real with respect to what goes on in science and being inclusive of members of that community. Yeah. Thank you for that, Nicole.
Thank you.
LaTasha, did you want to add to that?
Yeah, so there's a question in the chat about addressing trust, and I know Nicole touched on it, but trust and mistrust historically, when you're talking about communities of color, is evident. We've seen those abuses, we've read about those abuses, but we also have to recognize that we're now generations removed from that, and there are changing perceptions, especially in particular populations. I was having a conversation with a colleague in the research space about clinical trials, and there is a recognition that Keeys happen, let's just be honest, but there's also the recognition that without clinical trials, we wouldn't have Advil, we wouldn't have Tylenol, we wouldn't have most of anything we have today. The reason we have had, extensions in our lifespan is due to changes in our healthcare system, the ability to treat diseases, prevent diseases, vaccines. And so I really want to recognize that we have to have honest dialogue. I know Congresswoman Kelly had the Truth and Reconciliation, conversation during a past annual legislative conference. But I think we really need to get to something like that around clinical trials, have true, real discussions. And I do want to kind of counter what Nicole said about having the pharma company go out there. I think there's still a lot of mistrust there, but there was also a comment in the chat about having people who look like us talk to us because there's implicit bias. Having worked in clinical trials, that's one thing I heard from the sickle cell community is the fact that because of their skin color, their physicians didn't even talk to them because it was that implicit bias in the back of their mind saying, this is a Black person who's not gonna be interested because it's just Tuskegee. But that person was willing to listen and was willing to try. And I think that conversation has to happen. And we just need to break down those barriers, those biases, and those silos that happen and all come together to kind of have this conversation around them.
Well said to you both. Thank you for that. I want to bring the audience back in and see what we all think collectively are the leading issues for marginalized people. And it's clearly access to healthcare, right? that is an ongoing narrative, and then closely followed by COVID. And a lot of this is, again, momentous, right? But then behavioral health is a follow-up. And so I actually wanted to have a brief conversation for about 2 minutes about behavioral mental health. And someone had brought this up also. And so the question here, and I really like this question, is, how can behavioral mental health be addressed such that in this moment or the moments that follow, right, we don't end up attributing mental conditions, behavioral health conditions, to individual deficits. So we're making it more a population health discussion rather than a stigmatizing discussion around wellness, mental wellness. Does anyone want to comment on that?
I'm a neuroscientist by training, so
yeah, I knew you were going to jump right on it.
Well, you hit the nail on the head. NAMI has been doing a tremendous job during this conversation, but I think we have to destigmatize it. And in our community, we don't talk about a lot of things, but we definitely don't talk about mental health. We want to pray it away. We want to go and seek, prayer, but we don't want to go to counseling. We don't want to go see a physician because we think something's wrong with us and we don't want to be labeled crazy. And I think we have to break down those stigmas. We need to have some honest, frank conversations. We need people who have mental illness that look like us to come talk, because if we're always seeing people who don't look like us talk about it, we're gonna be like, oh, I'm gonna be that person in our community that everyone stays away from. So that's just my little 2 cents, because I could talk about this for a long time.
You could, and if you all ever have an opportunity to corner Tasha, in person or virtually, get her to talk about this. She will school all of us. Nicole, any additions?
No, I think Tasha stated it perfectly. We want to put our funny uncle in the back room and leave him there, and that's not helpful. So yeah.
Mm-hmm.
Yeah. Take privilege. Really
Please,
quick.
go ahead.
It was a wonderful Q&A question about the list that we provided. And I don't know who this anonymous person is, but I do want to say there was a wonderful book. Let me say what the question was. They said the question list didn't really talk about the social and political determinants of health. Yeah. There's a wonderful book that I know you and I both know.
Shout on out.
Very good colleague, Daniel Dawes, who wrote a book that was recently released called The Political Determinants of Health. And you're right, we did not include that in the list, and we were remiss of not do that. And I think it's really important because your geography and who you elect, let's be honest, can impact your health. You talk about the lack of Medicaid expansion in a number of states and the impact that's having on communities of color. I mean, we could go on and on, but we have 1 minute, so I'll stop there.
But we will have the link to Daniel Dawes' book, and as Tasha mentioned, definitely take a read of that, a deep read. They're doing incredible things down at Morehouse School of Medicine, where he's the director of the Stature Health Leadership Institute. And so we do have 1 minute left. I wish we had a whole another hour to dig into some of the things that a lot of people are bringing to the forefront in the chat and then also in the question box. But please continue to follow up with NMQF on the back end, because these are also conversations that between Keiko and Brandon and LaTasha and Dr. Pucker, and that we could put into additional conversations. But I open it up to Tasha and to Nicole to give us some closing words before we turn over to Brandon.
So I'll just close really quickly. Thank you all again for having me today. This is my first NMQF panel. I really want to encourage you all to get out and really research the candidates that you're voting for. Mia touched briefly on Medicaid expansion. I came from an office with a member from Texas where they have not expanded Medicaid. I'm from Alabama where they have not expanded Medicaid. And that simple thing that the governors could do would expand coverage and access for so many people who look like us today. So I just really want to encourage you all to think about voting and encourage your friends and colleagues to do the same.
Absolutely. I love all the chat in the chat box, and really appreciate all of the information that everybody's putting forth. And continue to come back to these conversations and continue to bring your perspectives as well as your additions, your pushbacks, your resources, all of it. There's a space for all of that here at the weekly NMQF conversations. And with that, I thank you. Again, I'm Mia Keeys. I'm with the American Medical Association, and NMQF is near and dear to my heart. And so I will be with you for sure in the next conversation.
So
Brandon, we can't hear you. There we go.
Oh, sorry. Can you hear me now? All right. Can you hear me now?
Yes.
Maybe. All right. Good. Well, thanks so much for attending. Learned a lot as usual. So this is my healthcare education that I get on a weekly basis. Even though I work at NMQF, I still learn a lot from every person that we're lucky enough to have present and put forth to you all. Want to just do 2 quick plugs. The Congressional Black Caucus Foundation's annual legislative conference is happening throughout the month. And Congressman Kelly's healthcare fall Braintrust that NMQF works with will be on September 16th. So if you want to see that, just please register for at the annual legislative conference website. Additionally, if you want to hear from folks like these folks that spoke today, and again, like Daniel Doss, the gentleman that they mentioned, he will be a speaker at our annual summit on health disparities, which we have virtually October 5th through 7th. So please get on the NMQF website and register there. We'll have great discussions for 2.5 days, and look forward to hearing from you. Like I always say every week, in addition to my supporting of a different HBCU, make sure you get out and fill out your census and vote. With that, have a good weekend, everyone. Bye.